Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with Keratosis Obturans. And for anyone who's new to my channel and is not aware of what Keratosis Obturans is, I will explain it in great detail during the course of the video. I also have a playlist on my YouTube channel where you can watch other procedures with patients who have Keratosis Obturans. And I'll just give you a case summary. This patient has been suffering from a blocked ear for a while, predominantly in this their left ear. This is the worst ear out of the two. However, they've been managing, and as many of us do, we just put up with it until the last minute when it gets really bad. And last week, it all came to a head. They were on holiday. They submerged their head under water, so water got into the ear and completely blocked this ear. They were really struggling to hear with this their left ear upon attending today. And in the last couple of days, they're experiencing otalgia, which is earache. Initially, I didn't suspect this to be Keratosis Obturans. No, it is really immediately impacted. I can't remember if I mentioned, but they also admitted to using a cotton bud, and that didn't really obviously help matters because it just further pushed it deeper and up against the eardrum. So initially, I just thought this was earwax, but as I was starting to remove this plug, it became apparent that in fact it was Keratosis Obturans. So what's Keratosis Obturans and how does that differ from earwax? So earwax is made up of three ingredients. The first ingredient is dead skin and debris and loose hairs. So around 60% of earwax is what we call dry matter. So it's dead skin, hairs and dust dirt in the environment. The remaining 40% is made up of two other ingredients, sebum, which is an oily, fatty secretion, and we also find that on our scalp. So it's secreted by the sebaceous glands, which are attached to the hair follicles. And the final ingredient in earwax is an oily sweat, which is secreted by the ceruminous gland, which is a modified alpocrine gland. And these are sweat glands, and ceruminous glands are exclusively located within the ear, under the armpit, and in our groin region, and it's an oily sweat. So it's a different sweat we get on our brow, which is more of a watery sweat. And so that's earwax. That's got three primary ingredients. Keratosis obturans is just dead skin. It's dead keratin, and it's skin that's shedded off the eardrum and typically the inner 2/3 of the ear canal, so the bony parts. It's the epidermis, the epithelial layer of skin. And that skin is keratinous, so it contains a protein called keratin. We also find that on our fingernails and on our hair strands. And Keratosis obturans is when the skin fully fails to shed and migrate. So the ear canal and the eardrum is lined up with a layer of skin. The skin that lines the outer third of the ear canal, the cartilaginous portion, is about 1 millimeter in thickness, and it's got three layers. It's got the epidermis, which is made up of epithelial skin cells, which is the outer layer. You've then got the dermis layer, where the hair follicles are found, and the ceruminous and sebaceous glands are. And then the third innermost layer is a layer of fatty insulating tissue and connective tissue. So collectively, it's about 1 millimeter in thickness. Whereas the skin that lines the inner 2/3 of the ear canal and the outermost membrane of the eardrum, it's just the epithelial layer of skin, the epidermis is the outer layer. So that's at 0.1 millimeters in thickness. And the ear has evolved over millennia to naturally expel dead skin from the ear. So as the skin starts dying and shedding, it also starts to move in a conveyor belt motion out of the ear, so that the ear is naturally cleansing itself. And then you get another layer of skin, and when that skin dies and sheds, it's replaced by another layer, and that dead layer of skin migrates. There's a continuous cycle, and any earwax sitting on the surface of the dead skin is also naturally transported out of the ear. So Keratosis obturans is when this skin fails to migrate, and instead it collects in a plug. In addition, as the epidermis skin typically sheds and dies, it sheds in like flakes. So it's almost like desiccated coconut. It's in almost little fish scales. It's got that appearance. It sheds, and When the epidermis skin cells or the epithelial skin cells are on the canal wall itself, they are attached, they're adhered in a tight matrix. But as it dies and sheds, it detaches from itself, from other skin cells, and it flakes away. So almost like an individual skin cells. But with keratosis obturans, and it's not fully understood why it's the case, but as the skin dies and sheds, it sheds whilst it's still in its tightly adhered matrix. So it's connected to surrounding skin cells, but the skin is dead. And this matrix then forms into a plug, and it is probably the most difficult thing to remove from the ear. It comes in different consistencies, but in this particular patient, I was describing it to the patient that it's almost like, well, not almost, it's almost identical to chewing gum. And this chewing gum has been pushed right up against the eardrum, and it's been squashed up against the eardrum. So the patient has been using a cotton bud, and it's just so difficult to remove. So by this stage, we're fully aware it's Keratosis obturans. As I said, it appears to be earwax. On some occasions, you can spot Keratosis obturans from a mile off. As soon as you look in the ear, you can just tell it is. So the characteristic of Keratosis obturans, it's got a lot of kinetic energy. And because this skin, it's folding upon itself, falling into a plug. And this plug of skin gets bigger and bigger and bigger. And it's got enough kinetic energy to start widening and eroding the ear canal. So Keratosis obturans comes in 4 grades. And a hallmark of Keratosis obturans ear pain. It's very unusual that a patient attends with Keratosis obturans and they don't have pain. And the reason why they have got pain is because this skin plug is forever going. Think about a rubber ball inside your ear up against the eardrum, and it's expanding. That's going to be painful. Not only is it compressing against the eardrum, and I'll come back to that, but where I've got the 2 arrows, that's where the ear canal is widened, and you can see at the bottom that arc. The patient has got a natural protrusion of the anterior ear canal wall, and both of these things is making this really difficult to remove. So this rubber ball is expanding and it's compressing against the ear canal, and the bone that surrounds the ear canal, the temporal bone, is the second most strongest bone in the body behind I think it's the fibula, if I memory serves me correct. And no, sorry, the femur. Sorry, do apologise. It's the femur. So just by stating it's the second strongest bone in the body, it gives you an idea of how strong this bone is. But this plug of Keratosis obturans is so powerful, and it can start to widen and distort and change the shape of the ear canal. And that's what's happened when I had those 2 arrows in particular. The ear canal, and you'll see it right at the end of this video, the plug has extended upwards into the posterior superior region of the ear canal. And so that's why it's painful, because it's pushing against the bone in the eardrum. So a grade 1 is when a patient attends with mild earache, and there's just the starting of the widening of the ear canal. A grade 2 Keratosis obturans is when they attend with moderate to severe ear pain, and there's mild expansion of the ear canal. It's visible, it's quite visible. So I would say this patient is a borderline 1 and 2, because they did report pain, but they wouldn't describe it as moderate pain. It was more mild pain. However, there is, although it's not substantial, there is quite a widening. You can probably see it here at the top. That plug is out of sight. It goes up. The ear canal is also slightly swollen in front of it, so it's almost engulfing this plug of dead skin. So that's grade 2. Grade 3 is when there's severe earache, moderate expansion of the ear canal, bleeding as well. So what happens when you've got a Keratosis obturans plug is you get connective tissue, you get this outer layer of skin, you get granulation tissue as well forming, and it has its own blood supply. And as you start removing the skin plug, you rupture the blood vessels inadvertently. It's unavoidable, really. That's because as the skin plug's coming off the canal wall, or the connective tissue breaks down, that makes the granulation tissue, and the blood vessels rupture. So a hallmark of grade 3 is bleeding. We call it contact bleeding. So you lift the plug away from the canal wall and there's blood there. And also another hallmark of grade 3 keratosis obturans is when you have, again, granulation tissue, and it's located at the osseo-cartilaginous junction, so about a centimetre into the ear canal, where the bony part of the ear canal meets the cartilage portion. And grade 4 is the most severe form, and it's when the ear canal is so widened, it's almost like a mastoid cavity. So behind, and in fact, the ear canal joins the mastoid bone. So behind the ear, you've got another bone called the mastoid bone, and it's air-filled, it's a honeycomb structure, and the ear canal becomes so wide it then merges into the mastoid bone. So you've got a significant widening. I think I've come across only one case, and that typically it needs to be surgically removed because the patient is in so much pain. It's just not possible to do that in a normal outpatient's appointment, and there could be other pathologies developed as a result of a grade 4 keratosis obturans. So that's really, really severe. So this patient, I would say it's a grade 2 because there is enough widening there for the plug to be really difficult to remove. So how do you remove keratosis obturans? Now, you must be able to identify it, because if you don't, it's going to be hard to remove, because there's certain things with keratosis obturans that you need to do. You need to really, when you get a suction grip, you need to, like, first of all, go all around the perimeter of the ear canal and start detaching it from the canal wall. However, it's still stuck to the eardrum, so you need to then get a good suction grip and wriggle it left to right, up and down. You want to just loosen it. You've got to be patient, in other words. It's not one of those things you can remove straight away. I used a hook on several occasions already, and forceps. Now, with this type of keratosis obturans, because of the consistency, because it's like chewing gum, it was so frustrating because I managed to get the hook in behind the wax plug, or the skin plug, sorry, and as I rotated the hook and started bringing it forwards, it just cut through like a hot knife through butter. It's so frustrating because I thought, we've managed to get the ear hook really deep into the ear, above and over the skin plug and behind it, and all I have to do now is slowly bring the hook forwards, and as I do, this plug will come out, and it, unfortunately, it didn't. It just cut through, it dissected through it. So you just got to be patient, and the best thing to use with the keratosis obturans is sodium bicarbonate drops as opposed to olive oil. I almost exclusively advise my patients to use medical grade olive oil. The only exception is when I've got a patient with keratosis obturans. And the reason why sodium bicarbonate drops works really well with keratosis obturans and olive oil doesn't, because sodium bicarbonate drops contains water. And I'm not a big fan of water, but because it's in a sodium bicarbonate solution, it's somewhat antiseptic, so it's safer than your normal water. And when sodium bicarbonate drops enter the ear, they react with certain acids contained within the skin plug. I forgot the exact name of acid, but it's kind of a carboxylic group of acid, and it's an acid that's secreted by the sebaceous glands. So it's an acid that we have in our ear. It forms part of earwax, and as the sodium bicarbonate reacts with that acid, it liberates into water and carbon dioxide, and during that transitional phase into carbon dioxide, you get foaming, you get bubbling action, you get effervescence of carbon dioxide bubbles, and that bubbling, mechanical foaming, effervescence helps to break up the skin plugs, the skin cells that are tightly adhered. So if you remember before, I mentioned with the keratosis obturans, the skin is still connected to neighbouring skin cells, whereas typically as the skin dies and sheds in the ear, they individually shed. These individual skin cells, they shed like fish scales. But with the keratosis obturans, think about a snake skin. That skin is still together, it's tightly adhered, the skin is still attached to one another. And that's the same with the keratosis obturans. So the carbon dioxide formation, the bubbling, the mechanical foaming, the effervescence helps to break up the skin cells and that tightly adhered matrix. In addition, skin is hydrophilic. It loves to absorb water. So it absorbs the water, and it overhydrates, and that causes the skin cells to swell and then the membranes to break up and burst. So it doesn't dissolve it, but it breaks it up better. With olive oil, it doesn't do that. It won't have the same effect. So olive oil really is not effective in this kind of case. So I'm 15 minutes in, and it may look like I've not done a lot, but believe me, we've done a lot. We've really attached around the canal walls. And there's no other way of removing this. I've used forceps. A Jobson horn, you just physically couldn't get in and behind because you'd be up against the eardrum. The ear hook, I've managed to glide it in, but it just dissected through. And you can see that bony protrusion at the bottom. That's a bit of a hindrance there. That limits our movement, and it also, the Keratosis Obturans plug is somewhat trapped behind that. So I've just put another dose of sodium bicarbonate drops in there. And if you look at the playlist I have on Keratosis Obturans, you can see they have one familiar theme. It's the time taken to remove. A normal earwax removal for me, I would say nowadays it's about 5 minutes, but Keratosis Obturans, it's very seldom you can get that done within, if it's a grade 2 and above at least, within less than half an hour. It's just a lengthy procedure because you just have to go through the motions of loosening it, detaching it. There's no shortcut really. So we're making good progress here. And I've just got a suction grip. I'm trying to wriggle this left to right, but because this plug, and this is probably something I should have explained in a bit more clearly and in detail. This plug that I'm removing is larger in diameter than the ear canal in front of it. So the best analogy I can give is imagine when you're constipated and you're trying to force stool out, and it's dry and it's hard and it can be painful. And it's the same for this patient. So the patient already attended with pain, so we're removing this whilst it's painful inside the patient at the end. Sometimes you read comments, oh, why don't you just get the hook in and do this and do that and remove it? Believe me, if that was your ear, you'll realise why we don't do that. It's the last thing we want to do, because it's painful for the patient. This is a real patient we're treating. It's not an ear model or mannequin. And if it was your own ear, you wouldn't want us, believe you me, to do what you're telling me another specialist to do. So it may be frustrating to watch, but I was enthralled by the procedure. I've not done Keratosis Obturans in a while, actually. I went through a phase where I was doing at least 2 a week, and then it simmered down, and I had this one today. So, and the reason why I like doing it is a real challenge, because I'm trying to remove it whilst making sure it's comfortable as possible for the patient. So we are slowly but surely getting there. You can see it's coming forwards, but it's hitting that protrusion, that front part of the ear canal that's protruding outwards, and that was also becoming a bit painful for the patient, and it's rubbing against that. So once more, I'm going to go into the hook. I'm gliding it over, beyond, so I'm just flicking it forward so I can get behind. Now I'm into it, I'm in the core, and I'm thinking, brilliant, again, I'm going to get this out. And once again, it just dissected through it. It's got this, it's a chewing gum consistency. It's almost stretchy and stringy. Although it didn't come out, I did break it up in the middle. So what I'm now doing is the outer bits, I'm trying to peel it off the canal wall and push it to the centre. So I'm trying to almost change the shape of this chewing gum. So I'm trying to make the size of the chewing gum smaller by bringing it into the middle, which then allows me to bring it through the ear canal. Now you're going to get a better view now of the widening. You can see the ear canal and the plug goes upwards. It's almost hidden. I'm trying to bring it down from the top. And on the left-hand side where I'm here, you can see that tightly adhered matrix of dead skin. So that white skin is the fresher layer of skin. That skin was only recently lining the ear canal, and it's shedded, and it's joined the plug, the main plug of keratin. And you can begin to see the widening of the ear canal now, where on the left-hand side of the canal wall, you can see it's red. So it's red because that skin that I just removed was attached to the canal wall. So you can see it's the same location, same size as two white patches of dead skin just below the suction probe. That was on the canal wall to the left where it's red. So the pure motion of bringing it away has just caused a bit of redness in the ear canal. But that plug was pushed up against the canal wall in that region as well. So it's compressing and expanding it. And I've more or less loosened the plug all the way around the southern hemisphere, but it's still attached at the roof, but I just can't get access to that because it's upwards. There's a widening there, and the canal wall obviously in front of it is preventing me to go up there, but I'm going to give it another go in a minute. I'm just angling upwards, and I'm just trying to tease it forwards. You can see here, it's as I'm bringing it forwards, the narrow part of the ear canal is trapped at the bottom. So I'm just trying to wriggle this, and I'm going to lift it up and over that a bit later. In fact, I think this tears off this bit. And at this stage, on the tissue, the patient's probably thinking it's been at my ear for 20 minutes and there's only a little piece of wax being removed, but they could feel the resistance in their ear. And at this stage, this is the final bit, the patient initially found it uncomfortable. So as I put loads of more drops in, the plug came off the eardrum and the patient could feel that particular point. So, but the patient remained still. I managed to remove it, and you can see it's coated with this dead skin. That dead skin, the rest of it had still remained on the ear canal. So it almost sticks to the ear canal because the skin is attached to the canal and also the plug, and there's a skin on the eardrum that was also attached to the plug of Keratosis Obturans. So it's almost, the ear doesn't want to let go of it. The skin acts like double-sided sticky tape. It sticks to the skin plug, and it also attaches to the eardrum and the canal wall. And you can just see how red the medial canal wall is. And that's where the plug was getting bigger and bigger and compressing against the canal wall. So that region is very tender. I just want to remove this next layer of skin. So this skin, if we left it there, I just don't think it's going to migrate in this patient. I think this patient's prone to developing Keratosis Obturans now. And this is the posterior superior quadrant of the canal wall. I just want to remove this for two reasons. I just want to make sure there's not an underlying cholesteatoma. A cholesteatoma can be a life-threatening plug of dead skin that normally accumulates in the attic region or the posterior superior, so the back top part of the eardrum, where the eardrum can get synced inwards. It can retract, buckle inwards. You get skin that drops and falls into that. But also I wanted to see how wide this ear canal was in this region. So they didn't have a cholesteatoma. This is not a cholesteatoma, but it could be one behind that. We don't know. So I wanted to remove it for diagnostic purposes. And you can see there's no cholesteatoma there. But it gives me a better perspective of how wide that part of the ear canal is. So go in. You can see that. Hopefully you can see that widening. Just where I'm angling there. So got that one out, and that was their worst ear. So we looked at this and we looked at each other and thought, do you think it's going to take us long? And I was pretty confident this wouldn't take us long. In fact, this took about 5 minutes, if that. I immediately put some sodium bicarbonate drops in. So the aftercare for this patient, they know not to get water in their ears now, and they know that they knew before they shouldn't be poking inside the ears because that's just going to make it worse. Just going to further impact that plug. I've recommended they use sodium bicarbonate drops on a regular basis, on a fortnightly basis actually. And as I said, the reason why I recommended sodium bicarbonate drops is because the water in the sodium bicarbonate drops will get absorbed by the dead skin cells. It will hydrate, swell and burst. So it'll stop it from building up into a plug, especially in that tightly adhered matrix that I was referring to earlier. And also because of the mechanical foaming of the carbon dioxide as the sodium bicarbonate reacts with the acid within the ear. That will also help break up the skin plug and avoid getting water in the ear, so don't submerge their ear under the water like they were doing. And I've advised them to either visit myself or, first of all, in first port of call, their GP or nurse, just to have their ears examined in 12 to 18 months, because it may be that, and I've got a feeling that the skin will accumulate, especially in the left ear again, because they've got a widening at the top part of the ear canal. They've got a narrowing in the midsection because that anterior canal wall bone is protruding outwards. So I've got a feeling it's going to be a regular thing for unfortunately now. But so 12 to 18 months, I want to remove it before it gets as bad. This is quite an extreme case. So the right side, although it's still difficult, it wasn't as complex as their left ear. I'm just using the hook, trying to get over and behind. So this one is probably a grade 1 Keratosis Obturans, as the other one is grade 2, or this is possibly pre-Keratosis Obturans. It's not technically Keratosis Obturans at the moment, but it would, without any further treatment, become so. So again, I'm just trying to bring this down away from the canal wall to the middle of the ear. I'm just trying to loosen it from the bottom of the ear canal. And this region of the ear canal is quite red. So again, this wax plug is beginning to compress against the ear canal wall. It's not widened it, but you can see it's in that process of doing so. I think we just put a bit more sodium bicarbonate drops in just to loosen it, lubricate the canal wall. And I'm going to try to release it from the bottom, so I'm going to hover this upwards. I'm just going to rotate the wax whilst it's in the ear, or should I say skin plug. There's a few hairs at the entrance, so they've got a bit wet because of the drop, so it's almost smearing against the lens of the endoscope. I'm just going to go a bit further in with the endoscope, trying to get through those hairs if I can. Bit of a narrow ear canal. You can see this part of the ear canal, it's about 0.5 centimetre away from the eardrum. It narrows and widens. We call that the isthmus. We all have this narrowing, some more prominent than others. And you can see it's now slowly working its way out. That's the eardrum. There's just some skin on the side of the ear canal. And as I was doing that, I was just trying to find out the acid. So it can react with acetic acid, but the other acid is carboxylic acid. A carboxylic acid, yeah. So I was just testing my own memory there. So it reacts with that in the ear, and it releases carbon dioxide and water. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.